Good afternoon. My name is David Camacho, and this presentation is for Christus Health CEO, Bernie Sadao. And today's topic is reducing 30-day readmissions in diabetic patients via predictive modeling. So we know diabetic patients are at high risk for 30-day hospital readmissions due to complex chronic needs. Because readmissions are costly and often preventable and subject to CMS penalties, directly impacting margins and quality scores are of our interest. Predictive modeling can help prevent readmissions with an estimated $11.87 million in savings for just this cohort. We aim to continue improved care coordination, reducing unnecessary hospital strain, and support data-driven population health. So, with all of that in mind, there are two questions of interest that we are wanting to solve and explore. And the very first question of interest is the following. Can we predict whether a diabetic patient will be readmitted within 30 days using EHR data? And number two is a measurement of HbA1c during hospitalization associated with a reduced 30-day readmission risk. So we came up with the following strategic solution that is going to allow us to create real impact, not only for our staff, but of course for all of our patients and improve the quality of life for them. We propose to build a predictive model to identify patients at risk for 30-day readmission using structured EMR data. And we propose a second solution to evaluate whether measuring HbA1c during hospitalization is associated with said lower readmission risk. And one of the things that we came up with is the logistic regression model. And one of the reasons why we did this is because we wanted it to be interpretable, to be able to develop actionable insights for our staff to follow. Our logistic regression model with L1 regularization captured 52 of the actual readmissions at an optimized threshold of 0.5. This enabled targeted interventions before patients return. With the precision of 17% and an F1 score of 0.26, the model is tuned to prioritize recall, surfacing more at-risk patients for review. And now, one of the most important things is, of course, seeing the impact in dollars. And so this financial modeling estimates 7.7 million in net savings, demonstrating business value of predictive intervention. So as we saw here, you have we were able to predict the readmissions for 1,187 patients, which is over half of how many were actually readmitted within 30 days. The second one that we also saw was the measurement of HbA1c. And so patients who had HbA1c measured during hospitalization had a 16.6 lower odds of being readmitted within 30 days. 11.4% were readmitted that were unmeasured versus the 9.9 that were readmitted that did have their HbA1c measured. And so this right off the bat, without really doing any other analysis, tells us that this cohort is smaller for those that did have their HbA1c measured. And so proactive A1C screening may be linked to better outcomes, not just the sole fact of measuring the metric, but because they did that, perhaps staff are being more proactive and also getting other metrics and providing a better quality of care. And also finding support, proactive care has low cost, actionable risk reduction strategy. So what would it take for this to get done? We've analyzed that. We built a logistic regression model to be able to see to be able to tune it for F1 score, and which is the best balance between recall and precision. Well, this is what it would take. The nurse or discharge coordinators receive risk flags via dashboards or EMR notification to guide follow-up steps. We would focus on high risk discharge protocols, patient education, med reconciliation, follow-up scheduling within 72 hours. We would have to develop and train medical staff on risk score and trigger the follow-up checklist. And at the end of the day, success improves when a nursing manager or case management lead owns the process and ensures accountability. So we have developed a dashboard that tells us, that gives us the exploratory data analysis, and it's a public link for staff to be able to use. The dashboard contained over 100,000 encounters, with 11,000 of those encounters being readmissions with diabetic patients. We would be able to feed in the data into this dashboard and have the EDA portion be updated continuously. We would also update the modeling portion as well and have this information updated as well as we go. And the key piece here that I would just really want to point out is that with our logistic regression model, we estimated an $11.9 million of savings by calculating over half, or predicting over half of the readmissions. Unfortunately, we also have to account for the patients that we calculated as being readmitted, but were not supposed to be readmitted, but that is still a smaller cost that we will incur, which leads into a cost of 4.2 million, and that leaves us a net savings of 7.7 million. So with that in mind, the ROI is clear. 11.87 million in potential savings, 4.2 million in estimated intervention costs for false positives, which led us with a net savings of 7.67 million. At the end of the day, this is what we have discussed today, and that is that 30-day readmissions among diabetic patients are common, costly, and penalized by CMS, yet often preventable. We deployed a predictive model that captures over half of readmissions with the focus on recall and risk flagging. Our model performance gave us a recall of 52%, a precision of 17%, and an F1 score of 0.26, yielding 7.67 million in net savings. Our key predictors, which are on the dashboard, are led to increased medications, frequent prior inpatient visits, and discontinued diabetic therapies, which we will discuss with the CIO and how to interpret them and what is increasing the odds. We also saw that HbA1c measurement was associated with a 16.6 reduction in readmission odds, supporting proactive intervention. And last but not least, we have targeted follow-up, better resource allocation, and scalable implementation across chronic care populations. So I look very much forward to continuing this development, to this implementation, not only for the better of our staff and to also have savings, but more than anything to increase the level of quality of care for all of our patients and every person that walks through that door. I look forward to hearing from you. My name is David Camacho. My email is listed there, and a link to the Power BI dashboard as well is available. Thank you so much, and I look forward to hearing from you.